In the chapter on abdominal pain and infections, there's just a few things I want to go over with you. You can do the reading about the individual presentations and conditions that are presented in this very short chapter. But there's a couple things I really want you to be able to discriminate. One is that abdominal pain is a common reason people seek care. And it's kind of challenging because the cause can be gas, or it can be an ruptured appendix, which is quite life-threatening. So being able to discriminate to the best of your ability is just vital for our patients' morbidity and mortality rates. So let's spend some time looking at pain and how you discriminate the different types of abdominal pain. And then I want to talk about location, because you can go through appendicitis and small bowel obstruction and perforated peptic ulcer disease, peritonitis, and that ruptured aortic aneurysm, and you can follow the path of the text, and you can say, okay, what's the definition? What's the pathogenesis of this? And then and the etiology of this. What's the typical clinical presentation of this disease? What am I more likely to find in physical exams, really respecting there's variations? And what diagnostic tests are typically run in that particular problem? And then management is very condensed and concise within our text, and complications and need for referral. It's the same pattern, and you need to wrap your head around that as you're going through these conditions. You certainly can't memorize it all, but you have to have that foundational base. So let's look at what I feel like will help you lay your base as an advanced provider. You have to recognize there's several mechanisms of abdominal pain, and including pain from obstruction of hollow viscous organs, distension, peritoneal irritation, mucosal ulceration, vascular insufficiency, altered body motility, nerve injury, abdominal wall injury, and pain that's referred. Okay, so being able to determine what kind of pain you're dealing with really is a diagnostic clue. So remember, abdominal wall pain is often described by constant achy feeling. Visceral pain, the pain arises from the hollow viscous, and it's usually a result of a distension or a spasm of a hollow organ, as kind of like, well, one example is the early intestinal obstruction. It's usually described as dull and crampy and poorly localized, versus and in sharp contrast with parietal pain, which is sharp, knife-like, well-localized pain, and that arises from irritation of the peritoneum. And you'll see that such as in acute appendicitis, okay, where the inflammation infection is spread to the peritoneum. Referred pain is an achy type of pain. It experienced away from the disease process, but it seems to be perceived as it's near the surface. That pain phenomenon of referred pain is a result of the shared central pathways for afferent neurons in different locations. So a great example is people will come in and the etiology of their pain is a inflamed gallbladder, but their complaint is their right scapula is killing them. So memorizing and knowing how to discriminate is this: abdominal wall, visceral, parietal, referred pain is vital in your diagnostic ability. Then the second thing to continue and think about on the abdomen is the location of the pain. Go ahead and divide right upper quadrant, left upper quadrant, right lower quadrant, left upper quadrant, and learn in the right upper quadrant. Generally, you're looking at some kind of etiology of pain from the chest cavity, liver, gallbladder, stomach, bowel, or right kidney and ureter. The left upper quadrant usually associated with heart or chest cavity pain, spleen, stomach, pancreas, especially acute pancreatitis, or the left kidney or ureter. The source of lower left abdominal pain include the bowel, left ureter, pelvis, and it's most associated with diverticulitis, particularly when the pain is protracted and severe. Right lower quadrant pain is associated with appendix, bowel, right ureter, and pelvis, with the most common diagnosis being appendicitis. So, inflamed gallbladder and peptic ulcer perforation has to also be considered when they have right lower quadrant pain. In some patients, abdominal pain is subtle, particularly or obscure in older patients where fever and pain are not elevated to the same height we see in a younger population. We also have to consider the gynecological etiology of a female's pain and must rule out ectopic pregnancy. So that pelvic is included in an abdominal exam. We are at the stage, and all of you are, that you recognize that the history is so important and the exam. And I cannot reiterate the need to lay this foundation by understanding the types of pain, the locations of pain, and including considerations, special considerations for age groups. If you look under conditions, I've assigned you specific conditions. The one I want you to spend absolutely the most time with is appendicitis. It's vital. You don't want to miss appendicitis. And you know, you don't want to miss any kind of acute abdomen, but you certainly don't want to miss appendicitis. And it's so frequently in our clinics. So take your time to look at all of the assigned conditions for this week. Take the time to look at the epidemiology, the definition, the pathogenesis, the clinical presentation that is typical, the physical exam findings that are typical, diagnostics that are used. You don't have to memorize them all. What's the top diagnostics that are used? What would you be using in the clinic? You know, you're probably not going to have a CT machine unless you work in the ER. So use your critical thinking and your common sense to say, hey, my management from primary care is, number one, the priority is recognize an acute abdomen and then refer them appropriately. Number two, with many of these conditions, I will be managing them. So, and then very concise complications and referral information is provided. This slide just shows the typical physical exam components and the diagnostic components we usually see that are around looking at an acute abdominal pain and infections. This slide is important because look at the huge amount of differential diagnoses. Makes sense since there's so many organs within the abdomen, and however, common things occur commonly. You cannot memorize every one of those differential diagnoses, but you will be able to connect them with that type of pain. What are the most common, with the types of pain and the locations of pain. And then I've said this before, that acute abdomen, what will kill our patients first? So those are the things you go for first to lay that foundation. You know, you're going to see a lot more urinary tract infections than you are at appendicitis. But you don't want to miss either one. But the appendicitis could kill them first. Again, management in the way Butero handles management, she just gives you a foundational base. So I'm not going to read those to you. You can do that, but wrap your head around how patterned she has provided within these chapters for you to continue to formulate your base on abdominal pain and infections. And this last slide simply takes that management and says, look, here's the top things that we do to manage abdominal pain and infections. Well, an acute abdominal pain, an acute abdomen is going to be sent to the ER or to the surgeon directly for surgical consult. A lot of abdominal disease and pain that is chronic really does require interdisciplinary management. IV hydration, because so many people have symptoms of nausea and vomiting or anorexia, and then proper analgesia from abdominal pain. Whatever the etiology will lead you to your choices of analgesia, and then the foundational value of treating the underlying cause. And if they have sludge in their gallbladder, maybe just a few stones, that's important. If they are provoking pancreatitis from drinking or from triglycerides that are 1,000. So again, finding out what that underlying cause is and being able to treat it and restore your patient's health.